Hello again. Welcome to the case management portion of this week. So this is really going to lay the foundation for the rest of our work moving forward in the term. So all of the assignments that we're going to be doing are based on case management, how we manage a caseload, how we manage a patient. And so um, many of us very well may be moving into the public sector of case management. So what this looks like is whether we are providing outreach services or working in alcohol and drug counseling, working in behavioral health, doing social work type tasks. To some degree, we are going to be involved in case management. Us will not see it all the way through, and I will show you the steps of case management or the pieces or facets of case management. Some hyper focused on one piece of that and working on a multidisciplinary team with folks who pick up the other pieces. Might be looking at this from start to finish. One other thing that I wanted to mention before we get started is that depending on if we work in the public or private sector of behavioral health, will kind of determine what case management means. But for the most part, it's going to have four basic parts, which we'll talk about in a second. I'm going to go ahead and share my screen here. We'll get started. Okay. So something that I thought was interesting to share was we're looking at a 12 to 15 increase over the next few years for the demand for case managers. Social workers, people with a master's degree or a bachelor's degree in social work, many of them go into case management functioning. And so what that looks like is this might be somebody working in the ED who sees patients who come in for a non-medical reason, and they will do things like find treatment beds, connect them with resources, connect them with social supports in the community. Um, to some degree, I am also a case manager, so I see patients through the entirety of a partial hospitalization program, which we'll learn more about later in this term. But the way that social workers, let's take in the emergency room for example, do case management is very again, it still has the same pieces, but it looks different. So in my case, I will do an assessment on a person. I will develop a treatment plan. I will hook them up with resources for aftercare or while they're in services. And then I will determine if the plan's still working. So those are the four basic parts of case management, which we'll go into in a second. But I wanted to share these statistics with you because whether you stop here in your education with a bachelor's degree or continue on to a master's in counseling, social work, human services, management is going to be something that comes up. For a lot of social workers, it's actually mandatory that you have a certification in case management, either mandatory or strongly preferred. And I did add that link. Once you have a bachelor's degree, you are eligible to take this case management course. It's kind of expensive. I wouldn't recommend doing it unless you know that you need it for your job. And again, case management in a private sector is more likely to require this certification versus community-based case management. And so I know that there are a few case managers in the class, and so we'll move more into the differences, but typically what you see is a quick turnaround case management. This is when somebody meets with somebody briefly, determines what their needs are, and then connects them with community resources. So that will be some of our experience. And then some of you will have tasks like mine where you follow a patient through from the assessment through the discharge process. And either way, they're going to have some major things in common. And so first, let's go over the definition of case management. So a collaborative process that assesses, plans, treats, or implements coordinates, monitors, and evaluates the options and services required to meet a client's health and human services needs. So at its core, case management is about transforming lives through individualized care and services so clients can meet their goal. So I know that we touched on this individualized care piece a little bit in the the cultural consider slides. Um, and and if we're using, I saw in some of the discussion posts where you kind of use this cookie cutter treatment plan or this cookie cutter plan of care for folks, and it will work in agencies that's kind of the norm. I would suggest challenging that norm. Of course, we can use a lot of the skills or teachings that we use for folks across the board. We can use them for multiple people, but it is really important to um, dive deep into the personal needs of folks and really individualize care plans. And so that's something that I really want people to understand is while we work in a system that says there's a formulary, there's a way for treating this specific diagnosis, we have to find creative ways to make it personalized so that they're still getting their needs met, the insurance is still covering services, but people are still getting that personalized approach. So some of the fundamental principles of case management are autonomy. So this is the empowerment and the understanding of independence that a person has. So to be autonomous means to be empowered, to have power to make the changes that we want to make. So really instilling that autonomy piece in folks and letting them know if it's actually true that they do have, if you're working with involuntary folks, this might not be something, but for the most part, we're going to be working with people who are in treatment voluntarily. And so somehow they've been empowered to come to treatment, and we need to continue to empower them and let them know that they can make it through and meet their treatment goals. Beneficence, so this is the idea of doing no harm. Non-maleficence, so we are essentially the idea here is that if we're not doing good, let's not do it at all. Let's get them to somebody else who can help. Um, and so we want to make sure that we have no malintent. We want to make sure that our intentions in working with folks is pure and authentic, as well as for the betterment of them. We want to make sure that there's no malintent. We also want to ensure that we are following the guidelines of justice. And so the definition of justice is going to be different from person to person in this class and the world. But what I want to say, for the most part, we are advocates for the people that we serve. We might not necessarily agree with somewhere that they want to go or places that they've been or what their intentions are. But for the most part, we work with that. We work with, first of all, the understanding that, and this makes it easier for me, it might not for everybody, but people are doing the best they can. And we need to advocate for their right to do so. So that's how I view the term justice in this case. So again, case managers come from different backgrounds within health and human services. There are nursing case managers, there are social work case managers, there are community case managers. So working in, again, nursing, medicine, social work, rehab, insurance and workers' compensation, and then behavioral health. So there's three major models of case management that we're going to look at here. And the first is the brokerage case management model. And so when we're looking at this is what I discussed earlier with the very little direct service to the client. So a good example of a brokerage case management model would be the 211 line in our community. So 211 is a number that people can call. It's a resource line, and there are people there answering the phones. So for instance, if I'm experiencing domestic violence and I call 211, they will get me squared away with domestic violence resources in the community. If I need a food box, they can tell me where to get one. If I want to go to a self-help meeting, they can tell me where to go. So that's a good example of this model. So serving as a direct link between client and community resources, but we're not doing counseling, we're not therapizing these folks, okay? In the clinical case management model, this is where the therapy piece comes in. So in a clinical case management model, a clinical care provider serves as the case manager. Frequently, we are counselors or therapists, and the model recognizes that many clients face barriers to service that reach beyond simple questions of access. So this is when we're actually teaching skills, we are helping, like, rather than guiding and connecting folks with resources, we're actually helping them engage in those resources. We are also utilizing that multidisciplinary team and maybe making calls and setting up appointments for folks, as well as coordinating their care across the board. We're making sure that they have a primary care doctor. We're making sure they have access to housing, access to food. So it's kind of this all-encompassing, holistic type of case management. So as a clinician, the case manager in a clinical case management model provides direct counseling for a client's individual concerns. This might include mental health, substance abuse recovery support, or treatment for serious and chronic health conditions. And the strengths-based clinical case management model is very similar to the clinical case management model. However, we're really hyper-focused on the empowerment piece. So again, I know across the board, I'm in a question that we kind of use this lens that the patient is the expert, not us. And so that's really sought after in this model. So our case management and services focus on creating client opportunities for growth, education, and skill development. We are going to hone in on their strengths and them and make them more broad, if you will. This model, as well as the critical case management model, really hyper focuses on community services, family, so those social aspects of care, as well as finding, it's not on the slide, but back to the purpose is finding what motivates folks, finding what makes them happy, finding their passions, and helping them really hone in and find spaces in the community where this can be emphasized. So at any rate, in either of the management models, there's going to be 4 major components of case management, and this is what we're going to do throughout the rest of the term. So we'll be doing an intake, we call it a biopsych assessment, but this is something that will be done when somebody enters services. So the needs assessment piece, so we've kind of combined that intake and needs assessment piece. As well in the work that I do, those are combined also. We'll get a referral and we'll have basic information about somebody. We make sure that they're appropriate for our level of care. And then we do the biopsychosocial assessment. Service planning, also known as treatment planning. So these are the objectives and interventions that we're going to explore. What are the patient's goals? How can we help? And then we're also going to monitor and evaluate. Are our services helping? If they're not helping, how can we change that? Who can we get them to in the community? And then also I explained earlier in the cultural considerations video, using standardized measurements potentially at the beginning and end of service. Did the service actually work? Have their goals been met? Have their needs been met? Their needs that we can cater to. And so this will be the case in any type of case management that you go into. All of these will be a facet. Like I said, we might be the intake coordinator, so we might solely be doing biopsychosocial assessments or taking referrals. There might be a discharge planner that maybe a social worker, for instance, that does the monitoring and evaluation and discharge piece, or the community resource connection piece. Um, but for the most part, we will have experience with these different components. So at the intake, so this is the initial meeting between a case manager and a patient or a new client. This is where we gather demographic information, any kind of background information that would help inform our service. This is also where we develop rapport and where we start really connecting with folks. It's the intake part of the work is really important because it's what keeps people coming back. So we want to make sure that we're creating a safe, comfortable space for folks, as comfortable as therapy can be, and that we're being transparent and fully disclosing what we offer, what we can do for the patient, what we can't do for the patient, what we don't offer, what their job will be as a patient, and what lengths are we willing to go, or what are we willing to share with the patient. Moving on to the needs assessment. So this is where we build on the information collecting during the intake. So the example that I used earlier, we have a referral process. We make sure that folks are appropriate for treatment, and then we move on to the biopsychosocial assessment. So this is where we expand on the information that we've already had. Okay, so I know you're depressed. What does depression look like? What do the symptoms look like? How is it affecting your life? How do your we'll collect information on historical experiences and start to do some research and gather some understanding as to how their historical experiences inform the way that they live now. During this stage, a case manager's objective is to identify the client's problems, interests, and barriers or risks to success. While every client goes through the stage when they first come to an organization, it's important to reassess time as needs and circumstances often change. So in my case, we typically have folks in the program from 2 to 3 weeks. We don't do, we do mental status exams, which you'll see later on in this class. And that is how we assess needs over time. So we make sure that people have aftercare set up. We make sure if they're on medication, if the medication's working, or if they're experiencing side effects. And we really focus on the original symptoms that they came in with. Are they diminishing? Are they getting better? Are they getting worse? If they are getting worse, then finding an alternative alternative path of action, or referring to a higher level of care, maybe. So we have a lot of folks who come in with suicidality. They might not have intent or a plan. They just feel like life's so overwhelming, and they don't want to live anymore. Well, something could change during their time in the program. And they're like, okay, well, I actually do intend or on killing myself, or I am planning to attempt suicide. And so those are the type of changes that we really need to focus on so that we can get them to the appropriate level of care and get them safe. So serving or treatment planning is important to the success or failure of a client. So not only is treatment planning conducive for the patient because they know, okay, here are my goals and here's what the agency or the counselor is willing to do with me to reach my goals, as well as it's good for the agency because we have measurable, we have documentation and measurable interventions that we can present to insurance companies, to our employers, and say, hey, the service is working, or no, the service is not working. So treatment planning is actually something that we have to do by law. And so I think it's within, it might be 72 hours, or maybe it's changed, but within 72 hours, we need to have a service or treatment plan for folks, and they have to be a part of it. And so at my work, and you'll see how we do this in the treatment planning, the goals are always going to be in quotes. They're always going to be something that has actually come out of the patient's mouth. This is my goal. This is why I'm here. And then we will discuss and agree upon the intervention that we offer at the program and which ones that they will help for them or which ones that they're willing to do. So we're going to talk about SMART goals later in the treatment planning week. But just to reiterate, outputs and outcomes should be achievable and measurable. So for instance, we're not going to say something as vague as I want to be happier. That's not something we can necessarily, I mean, I guess we could measure it, but we want to see, I want to stop engaging in self-injurious behaviors. I want to stop drinking so much. I want to stop, you know, not being able to go to work because my symptoms are so unmanageable. Something like that. Something we actually measure. I could take a step back and objectively say, yes, this is happening. So something that you'll see if somebody wanted to, let's say their goal was anxiety management, and we've agreed that they're willing to um, mindfulness skills or grounding skills. So the goal would be to manage anxiety, whereas the intervention piece would be attend the following groups on grounding, anxiety management, whatever the case may be. And then we can look back and say, oh, they did go to this group, this goal was met. So we're not saying that they're going to manage their anxiety perfectly, but what we are saying is that they are willing to go to this group. We offered it, so we've met that goal. Okay. Monitoring evaluation. So this is critical to understanding the impact of our programs. If our programs aren't working, then we need to change something. And so something that I've noticed at my job is that our evaluations fluctuate depending on our staffing, how many folks we have in the program, who's actually teaching the groups. We will get different feedback about the program, and we will have we'll see more or less of a change on folks' standardized measurement scores depending on those dynamics that are happening in the program. And so by looking at those evaluations, we can determine like, oh, maybe we shouldn't have that community partner come back and do groups. It didn't seem to be well received, or this intervention that we're using isn't working, or people seeing this dietitian are reporting that they didn't get much out of it. We get to use that feedback in order to inform our services in the future. So evaluation and data ensure client success is quantified and qualified rather than anecdotal. So we want to make sure that we have hard evidence that our treatment is working rather than just people saying, yeah, it was great. While we love that people say that, we also want to essentially be able to prove that our interventions and what we're doing is actually helpful for folks. So, hold on one second. So like I said, we will be moving through these pieces throughout the rest of the course. Next week, we will be moving into assessments, and the week after that, moving into treatment planning. And then we'll be talking about suicide risk assessments, different standardized measurements, just some of the really common ones, how to do a basic mental status exam and an DAP note. And then we will be working through discharge planning, connecting with resources. Please pay close attention to the reading and the case management portion this week. I think that it's appropriate to skim, but paying attention to the discussion portion of the article is going to be really important. So please remember that while you're reading. If you have any questions about case management, and I'm looking forward to seeing you all on Zoom this week and working through the assessments, and I will talk to you soon.